So I would like to share the another important atherosclerosis, aortic atheroma. So as all you know, aortic arch plaques are important cause embolic sources in cryptic stroke and ESAS. And the original concept of embolic stroke of undetermined source ESAS would be comprised of the a covert atrial fibrillation patient. But in clinical practice, we cannot find covert atrial fibrillation as such. But we frequently encounter such situation atrial arch plaques. So this is very old data from Pierre Amarenko. He presented the importance of aortic plaques of the cryptic stroke cohort. And sometimes we can encounter such patient. This is a 4D ECG gated 4D CT angiogram. You can see the movie. You can see the plaques moving here, and this is a 4D reconstruction of the aortic lumen. You can see the plaques floating in the near the three main branches of the arteries. In such patient, there are several studies uh, investigating the optimal anti-thrombotic therapies. Is it good for use the anti-platelet or anticoagulant? So all the data, ASA or now, would be better than vitamin K antagonist. And another study shows antiplatelet therapy might be better compared to the anticoagulant therapy. But the PICS study, ASA, anti-acetyl salicylic acid 325 milligram, is similar to the vitamin K antagonist warfarin therapy. And the recent study, Amarenko did the ARCH study, warfarin might be better compared to the dual antiplatelet therapy. So according to these old studies, choice of appropriate anti-thrombotic therapy is not uh, clear still. And recently, one of the ESAS trials, Navigate ESAS, have a sub-study of the aortic atheroma patient. So this study was compared the rivaroxaban 15 milligram once daily compared to aspirin 100 milligram once daily. And the results were a little bit better with the anticoagulant therapy. So our Japanese guideline have a comment on the crippling stroke or ESAS with aortic atheroma. Current recommendation is warfarin therapy. INL 1.5 or higher may be considered instead of aspirin, but the recommendation grade is C and the evidence level is low. And some addition is a comment on the rivaroxaban. But still, anti-thrombotic therapy, best anti-thrombotic therapy is not evident for the patients with aortic atheroma. So, our colleague, Professor Ueno in Juntendo University, did a very pilot study using statin therapy for the patient with aortic arch plaque patient. He prescribed only 5 milligram once daily rosuvastatin 12 cases compared to the control cases of 12 patients. As a result, LDL cholesterol level lowered to the less than 70 from the 120, but not for the control group. So the less than 70 milligram LDL cholesterol control, what happened to the aortic atheroma? So this is the data of the transesophageal echocardiography. Left two panel shows the result of the rosuvastatin group, and the right two panel shows the control group. So from the beginning, aortic atheroma has a very heterogeneous component, but as time goes on, within 6 months therapy of rosuvastatin, the plaque composition significantly changed with rosuvastatin therapy. The plaque has stabilized, but not for the control group. So in aortic atheroma, we need to concentrate on the lipid lowering, and the stabilize the plaque is very important. It is superior to maybe superior to controlling the anti-thrombotic, dual antiplatelet, or the anticoagulant. It doesn't matter. So best option for the aortic atheroma stabilizing is statin therapy maybe. So aortic atheroma would be a good candidate for the lipid-lowering therapy rather than anticoagulant or the antiplatelet or dual antiplatelet therapies. So I would like to show this case. As aging population, we encounter aortic atheroma more frequently than before. So this is my presentation, and I would like to get many comments from the experts.
Mhm. Well, actually, I had a similar case, which was not an aortic arch atheroma, but the carotid artery atherosclerosis. And after using a PCSK9 inhibitor and lowering the LDL cholesterol to 20 or 30 milligram per deciliter, the atheroma did regress in the severity. And the stenosis was better just by lowering the LDL cholesterol. So I think if we lower the LDL cholesterol, it may regress the atherosclerosis in some portion of patients. Additionally, we can also have some effect on the plaque stabilization. From the carotid duplex study, if we use an hydrostatin and reduce the LDL cholesterol level, the lipid-rich atheroma have changed to fibrosis-rich atheroma, which is a more stable plaque. So, thinking the nature of the aortic arch atheroma and the mechanism of stroke, I think using antiplatelet or in some cases anticoagulation and also reducing the LDL cholesterol may be beneficial for reducing the preventing the second stroke. So I do totally agree to Dr. Hirano's opinion about treating aortic arch atheroma patients.
Thank you for the comment. And one thing I would like to add, if we had carotid plaques, we have other options such as carotid artery stenting or the CEA, carotid endarterectomy, but we cannot remove the aortic arch atheroma unless we have another other heart surgery. So more important in patients with aortic atheroma to do the lipid lowering. I think this is a good candidate for the PCSK9 treatment, I think. So I would like to have another case studies with PCSK9 to stabilize the aortic arch plaques. Maybe same result will be observed as you show on the carotid plaques, I believe. Thank you.
Dr. Hirano, I have a simple question. I do agree in treating the patient with lowering the LDL cholesterol. Um, I would like to ask how to evaluate those patients. Well, you have performed a TEE, transesophageal echocardiography, but in some cases of patients with severe stroke, it is hard to perform TEE. Do you think a CT looking at the aortic arch may be helpful for those patients, and also considering the anatomy of the aorta, the location of atheroma may affect also the location of the lesion. For example, if there is atheroma in the descending aorta, it may not cause infarct in the right MCA territory, though there is some backflow which can make the thrombi emboli to make a backflow. Do you think in patients with ESUS or in those who have an aortic atheroma, do you think CT can give additional information, or do you think TEE is still the gold standard for those patients?
Yes, yes, it's a very good question. I think to evaluate the aortic atheroma, TEE, transesophageal echocardiography, is the gold standard and it's a mainstay still. However, nowadays, in the COVID era, transesophageal echocardiography is very dangerous for patients suspicious of COVID. It causes so much aerosols to have a spread of the virus for the atmosphere. So we prohibit using TEE compared to the those days pre-COVID era. So we are focusing of using other modalities to evaluate aortic atheroma. So the CT is one candidate for the evaluating the aortic plaque. Uh, we use the 4D CT angio using the ECG gate system. So we can evaluate the mobile plaque using CT angiography. Usually CT angio do not have such a high time resolution, but we can uh, arrange and sophisticate it to evaluate the mobility of the plaque. So such a plaque is very a dangerous one, I think, and we can treat using this modality other than TEE. Thank you very much.
Thank you, Hirano. I have additional question. You have followed up the T after 6 months of treatment with LDL cholesterol lowering agents. What timeline? What do you think is the most good uh, time gap to follow up the treatment effect for the aortic arch atheroma?
It depends, but the protocol is only using the entry time and 6 months period. So we don't know the exact adequate timing of the follow-up TE. Maybe 1 month or maybe 3 months would be good to evaluate. But the TEE is very harmful for the patient. It's very difficult to swallow for the old patient and the patients with consciousness disturbance. We cannot do the Valsalva maneuver or other detailed TEE evaluation. So it's a good question, and I would like to check my patient with PCSK9 treatment and the timing of the plaque stabilization. I think PCSK9 can reduce the timing period of the plaque stabilization. I hope so.
My last question is about the LDL cholesterol target. If the patient had an atheroma in the aortic arch, and at your follow-up it does not decrease, in that case, would you reduce the LDL cholesterol target for those patients?
I don't know, but I will first target with less than 70. But if we cannot, we will change the target less than 55. Then, as you say, 40. We have a weapon, so we can do that. Thank you.
Very good cases and the trials. So I just want to know that the you just use the statin 5 milligram, and I'm not sure um, how the patients will get the target, maybe less than 70 milligram or
Yes, the average is getting to the 67, so the loss of 5 milligram would be enough for this cohort.
so. In Japan, I think maybe patients are very sensitive for the statin treatments, right?
Right? That's right. So I think rosuvastatin is one of the strong statins. It's frequently used for the acute stage, and maybe most of the patients can tolerate 5 milligram.
So I have a quick question that is why it's so sensitive in Japan? Maybe because the weight of the patient weight, what's it? Body weight.
Mm. Weight, maybe. Yes, body weight is maybe thinner compared to the Caucasian population, but I think it's same to Chinese or the Korean population.
Professor Hirano, that was a very interesting case. Thank you for sharing it with us. I guess it brings to mind the fact that Japan probably has one of the oldest populations in the world, and this effect of arthromatous plaque needs to be looked at with perhaps a little more detail. We have an aging population here in Australia as well. I feel that we often forget that not every embolic stroke comes from the heart, and your case illustrates this perfectly. That arthromatous plaque within the large vessels and feeding up into the brain need to be given due consideration as well. I guess our issue now is that if antithrombotic guidelines or an approach to antithrombotic use in these patients is still not clear, it's obviously uh, an area that probably needs quite a bit more research so that we are better prepared in how to assist our patients. Arthromatous plaque being what it is, lipids being a major part, it comes as no surprise that aggressive lipid lowering strategies might actually might actually give us some hope. And your case again, I think, illustrates this very clearly. So I would think that hopefully what we're going to be doing is using fairly aggressive lipid lowering strategies with use of a statin to lower total cholesterol and LDL to treatment targets. And then, of course, in those patients who don't reach treatment targets, consider our options, including PCSK9 inhibitors.